تسمعوني؟ تسمعوني كلكم؟
يعني ما أتوقع ده يسموك أكو واحد من الطلاب يقدر يفتح المايك ويحكي.
أي دكتور نسمع.
تمام، أوكي.
يعني دكتور سمع.
خلي نسوي المحاضرة. هو كان مفروض obstetric and gynaecology history taking، بس هو موضوع واسع، فخليت الجاينيكولوجي هالمرة، ونكست تايم إن شاء الله نسوي الobstetric حتى لا تتلخبط عليكم إن شاء الله. ف عندكم شوية فكرة من الهيستوري تيكينج؟ يعني هسه أنتوا أول مرة لو كل anatomy physiology وهاي you haven't done any clinical work or history taking؟
أما أكو طلاب من غير كليات، يعني مثلا مرحلة رابعة، مرحلة ثالثة من كلية طب قارئ، يعني عندهم فكرة.
Good. Okay, so we're gonna start taking gynecological history. I'm Dr. Mahmoud, Imad Mahmoud, in Australia, Sydney. I teach in University of Notre Dame, medical students, and this medical student from Western Sydney, one medical student from Al-Ayen University. ونتشرف بكم. طبعا عندي clinical practice مالتي is different. I'm not just only educator. Education is probably 10% of my work, but 90% I do clinical work. So let's start with why gynecological history is different from other history. Why from medical history, comparing to medical history taking or other specialties of medicine. Because it is very sensitive area. It's about women's health, and it can touch very private issues about women's health, including sexual health, and that's why you have to establish very good relationship with the patient, gain the patient trust before you start going into the depth of history taking. So you have to have a structured, systematic approach and tailor your history taking to the complaint of the patient, and focus on the problem. So, for example, if we look at the frequent problems that the gynecological female patient will present to you, they usually come with abnormal vaginal bleeding, pelvic pain, urinary incontinence. Sometimes they feel vaginal lump or a bulge or discomfort, and that could be usually depending on the age, or if they had birth in the past, normal birth or cesarean section. So they usually would like say, I feel there is a lump in the vagina. If she's old or had multiple vaginal births, you should think about vaginal prolapse. But if she's got a feeling of lump that is not, someone didn't have vaginal birth before, you should think about other stuff, like is there a cyst? Is there a cervical cancer or lump or something? And they also might come to you with sexual problems, including painful sex or discharge or tenderness. The other thing is STIs. STIs means sexual transmitted infection, like gonorrhea, chlamydia infection, and other stuff. Contraception is another problem. They present to you, they were asking for contraception, whether they want to do oral contraceptive pill or stuff like intrauterine contraceptive device, or they might come a couple with infertility problems. They can't fall pregnant, for example. Cervical screening test. We used to call this pap smear when they do smear regularly. I don't know whether they do it in Iraq or not, but in Australia or in the Western societies, they usually do cervical screening test, screening for precancerous cells in the cervix to minimize the risk of or incidence of the cervical cancer. They might come with abnormal smear and you need to manage that, or they might come with a menopause problem. Older lady feeling hot flushes and vaginal dryness and mood changes, sweating, insomnia, all because she's going through menopause. So as you see from one slide, you can have a variety of gynecological problem. So you need to see what is the main problem of this patient. How old is this patient? Is she 18? Is she 75? Is she 55? Is she 40? Is she complaining of one of these issues? Like, this is a summary of issues that might come to you in gynecological practice, but there are others. Of course, I didn't want to, because we have limited time, I wanted to focus on the main problems. So you need to focus on the presenting complaint, or we'll start with open question. What's the open question? Hi, Mrs. So-and-so, or Ms. So-and-so. يعني بالعربي آنسة أو سيدة إذا متزوجة، Mrs. إذا متزوجة Miss. Start with open question. How can I help you today? How are you feeling today? Why did you come to see me today? So open question. So the patient will say to you, doctor, I am coming for this reason. So from the first word, you can try to limit your history taking to the problem. And when they say to you, I'll be coming with this problem, whether it's pain or bleeding or incontinence or vaginal prolapse or infertility, and then you need to see how is this problem impacting the life. Is it affecting the daily life? Is it affecting her work? Is it affecting her sleep? Is it affecting her relationship with her partner? And what's her main concern? What is the main concern? Sometimes they come to you, for example, with pain and bleeding and infertility all at the same time. So it's not only one problem. So I always think, okay, is your problem mainly, for example, your period is heavy, you're bleeding a lot, or is it the pain? Which one is worse, the bleeding or pain? You need to like focus on what is the most bothering factor to the patient. Let's go to the next slide. All right, for example, if we take the pain as an example, so when you go to the pain is always the same. That whatever you have in medicine or surgery or gynecology or obstetric or anything, if someone comes, you go to your basic rules. Where is the site of the pain? When was the onset of the pain? So usually in the gynecological surgery or gynecological patients, you find the site of the pain usually in the lower abdomen or in the suprapubic area. And onset, was it sudden or gradual? If it's sudden, for example, in a young pre-menopausal lady, if someone says, say to you, I have sudden pain in my lower tummy, you think about something ruptured, like ovarian cyst or hemorrhagic cyst or something like that happened. So that information helps you to narrow your diagnosis to certain topics. Or if the pain is gradual, that's mean it is not something happened suddenly. So you need to focus on something like other than a rupture of cyst, for example. The character of the pain, is it sharp? Is it dull? Is it pressure? Is it throbbing? And is it radiating to the back, to the leg, to the vagina? So you need to ask all these questions. Associated symptom. Is the pain associated with nausea? Is it associated with fainting? Is it associated with fever? Is it associated with anything else? You can ask. and timing of the pain. Is it around menstruation? If it's around menstruation period, around the menstrual cycle, you need to think about endometriosis, for example, because that's when the pain comes around the period. Exacerbation and relieving factor. Is it worse with the periods? As we said, is it worse with the sexual intercourse? Is it worse with defecation? Is it worse with movement? Is it worse with food? And what's the relieving factor? Some people say I put hot pack, خلي مي حار أو يسموها فتشي حار يتحسن، أو أخذ بنادول، أخذ neurogesic, Nurofen or something, it will make my pain better. Severity of the pain. What is the severity of the pain? We always use the score from 0 out of 10, and you say to the patient, if your worst pain is 10 and no pain is 0, how do you score this pain? Someone says, actually it is 2 out of 10, so you know it is mild. And someone says it's 9 out of 10. And you can ask them, does it stop you from doing, like if you're washing the dishes, when your pain comes, do you stop? If you are a teacher in the school and the pain comes, do you have to sit down and stop? All these questions will help you to assess the severity of the pain and then the seriousness of the pain. Similar approach can be adopted for the presenting complaint. If it is bleeding, if someone comes to you bleeding, usually female patient comes with bleeding from the vagina, and that's the main issue. And you ask the onset of the bleeding according to the cycle. So is it the period time? Is it out of the period time? If it is period time, then you know, okay, this is her normal period. If it is not the period time, is it mid-cycle? Is it 1 week after the periods? Duration, how long the bleeding has been. Timing in relation to the period. As I said, is it within the period or outside of the period? Associated symptoms, is it the bleeding associating with pain? Are you passing clots? Are you fainting? Are you breathless? Are you having fevers? And what can relieve it or what make it worse? And have you ever had this bleeding before? Okay. Always check if previous similar episode including any treatment. So menstrual cycle, duration, frequency. So if you're asking about the menstrual cycle, you're going to ask them how often you get your periods. Do you get it every 28 days? That means it's regular period. Is it irregular? Is it coming every 32 days? Is it coming every 45 days? So frequency, if someone says to you, every 2 weeks I have periods, what do you call this? It's called polymenorrhea. If someone tells you every 3 months I have period, then you know this is called oligomenorrhea. So they get less often or more often. How heavy is the period? If you have heavy menstrual bleeding, it's called menorrhagia. And these people, for example, some might tell you, my period is very heavy and how can you assess? Because if a woman says to you, my period is heavy, too much bleeding, but how do you know? Because some people bleed heavy, but they think it's normal. And some people bleed normal, they think it's heavy. So a smart doctor will say, how many pads you change? You know pad? الحفاضة اللي يستعملوها النسوان بالperiods مالتهم بالعادة. قولي لها how many times you change the pad. And how big is the pad? Do you use small pad or large pad? And if she says to you, oh, I use large pad, but how often you change the pad? I change it twice a day. So, you know, it is not that heavy. But if they say every hour I go to the toilet, I change my pad, and then 1 hour later, it is full again. And I pass clots and flooding. يعني أخلي الباد بعد ساعة أشوفه مليان أروح أغيره. هذول الشيء يسوون يعني هذا heavy period. So you need to analyze when they say I have a heavy period, because I have patients, they say, oh, I have period, you know, I change the pad every 1 hour. I say, well, is it full of blood? They say, oh no, because I feel dirty, I go and change it. So they have 1 drop of blood, they go and change it. So that's not heavy period, even if they change often. And is this periods becoming more painful? It's called dysmenorrhea. So I would like you to go today, get the glossary of gynecology. There's a terminology of gynecology, all these words. What's dysmenorrhea mean? What does dyspareunia mean? What is menorrhagia, polymenorrhea, oligomenorrhea, and all these things. So someone asking a question. Some questions. Okay. And when was the last period? It's important. You always ask, when was your first day of the last period? Because you want to assess. If someone tells you a period was 3 months ago, then you think, okay, why is this patient didn't have periods for 3 months? Is she pregnant? Is she have polycystic ovary, hormonal problems, and that's why she's not having periods? And then I always ask, well, how old? Menarche. Menarche is the onset of the first period. Was she 9 years old, 12 years old, 14 years old when she had the first period? And when was the onset of menopause? Because you remember your patient in gynecology come to you from 14 years old up to 80 years old. So they come with a variety of problems according to the age of the patient. You ask them, how old were you when you stopped having periods? And the definition of menopause, and when they have at least minimum 12 months of stopping the periods, then you can call them menopausal. And when they say to you, I was 52 when I became menopause, then you will say, have you used hormonal replacement therapy? Do you have any symptoms of menopause? Do you get hot flushes? Do you have vaginal dryness? So you want to help them, because they come to you probably because they're having a lot of menopausal symptoms. If they young premenopausal, you always think about gynecology premenopausal, postmenopausal, because the premenopausal problems usually different than the postmenopausal problems. So if they are on oral contraceptive pill, يعني حبوب من الحمل, when did they start taking it? When did they stop taking it? And what type of contraception pill they taking? Is it combined or progesterone, estrogen and progesterone? Is it progesterone only? So you need to know what type of contraceptive pill they're taking. Next slide. Sexual history. When was the first time they started having sex? That's a very important question. Sexuality, but this is probably more relevant in the Western society. Are they heterosexual, homosexual, or bisexual? Because you want to know your patient, if they are homosexual, they have different STDs, sexually transmitted diseases you need to screen for. And are they with one partner or more than one partner? And also, what sort of protection they use? Are they using condom during sex? Vaccination. Have they had hepatitis B, hepatitis C vaccine? And there is another vaccine we use in this Western society called Gardasil, which is against the HPV virus to protect against cervical cancer. You know that HPV virus, human papilloma virus, can go into the cervical cells, and the cervix cells can change into precancer cells, CIN1, CIN2, CIN3, then cancer. So there is a virus, they give it to the girls in the school at age 12 and 14 or 15, something like that. They give 3 doses, and that protects them against the HPV virus, which causes cervical cancer. So with this, they reduce the incidence of cervical cancer significantly in the Western societies. Check for sexually transmitted infection, and cervical screening test, which we told you about, is a screening for the cervical cancer. Obstetric history. When you take gynecological history, you need to also briefly touch on the obstetric history. Say, have you been pregnant? Have you had miscarriages? Have you had how many live births? How many miscarriages? And if she has children, how did you have your child? Cesarean section or normal vaginal delivery? And then you take family history. Do they have bleeding disorder or coagulopathy? For example, you might have someone having heavy periods or heavy menstruation, and you go and do ultrasound, there is no fibroid, no other causes, and you find they might have a coagulation problem, like von Willebrand disease, or some sort of clotting factor issues that it is causing bleeding, and then you pinpoint straight away and send them to the hematologist to treat the clotting factors or hematological problem. Do they have family history of gynecological cancers like uterine cancer, ovarian cancer, breast cancer, or bowel cancer? The bowel cancer is also, there is I don't know whether you guys know about the Lynch syndrome, that it is a syndrome when they find that breast cancer and ovarian cancer and bowel cancer is a syndrome. It has a gene that shares between some families. Some of them present as ovarian cancer or breast cancer or bowel cancer or both. So if you find someone says, my mom died with breast cancer and my auntie died with breast cancer, and my great auntie also had, grandmother also had a breast cancer, you always think about the BRCA gene, BRCA1 and BRCA2 gene. Say, okay, maybe there is a cancer gene in this family. So you need to, that history helps you. Past history, past gynecological problems, and how did they treat it. Medical condition. If someone has a medical condition, anything, liver problem, hemochromatosis, past surgery, have they had any gynecological or non-gynecological surgery? For example, have you had surgery for a fibroid? Have you had a surgery for ovarian cyst? Have you had a surgery for ectopic pregnancy? Have anything gynecological or even non-gynecological? You need to take surgical history, what type of surgery they had. And if they tell you, I had my tube removed because I had, for example, for ectopic pregnancy, you say, was the surgery open or laparoscopic? Or they might say to you, I had ovarian cyst removed when I was 20 and she's 40 now. And you say, okay, when was the, was it done laparoscopically or open? Because this is all you need to document in your history. And then I usually like to draw. I draw the abdomen and I look at the patient tummy, abdomen. If the scar is vertical, I draw a vertical line. If the scar is transverse, I put a transverse line, because always it helps me when I open patient's history. When I look at my drawing, I remember straight away what sort of scar she had, because that helps me to plan my future surgery. So if someone had multiple laparotomy scars, I know they have adhesions inside. So I need to be careful and plan my surgery. Social history. Do you smoke? Do you drink alcohol? Do you do any recreational drugs like marijuana? Do you do heroin? Do you do whatever, anything? Home situation, social history is very important. Do you live by yourself? What is the social situation of the patient? Is she living with a partner, with a family? How is her support network? Is she homeless? Is she on the government assistance? Because that all these things will help you to reach a conclusion about the diagnosis. Because a lot of psychological issues can happen because of the home situation and the support network of the family, of the friends, aqarib, asdiqa. It's all important. Is she taking any medication? What sort of medication? Is she have blood pressure, diabetes, cholesterol medication? Does she take antipsychotic medication, psychiatric illness, any over-counter non-prescription medication, any vitamins, and why she's taking it? Is she allergic to any medication? Is she allergic to penicillin or any antibiotic or any other medication? It's all to complete your history. That was briefly, I wanted to summarize it. So I think we are 38 minutes now. I'm sorry, it's a big subject, and to make it in half an hour or 40 minutes, I have to really cut it short. So إذا عندكم أسئلة تفضلوا.
عاشت ايدك عمي. طلاب اي احد عنده سؤال يقدر يسوي ريس هاند ويفتح الميوت من
وانا
بعد
موجود، ما عندي
اسمه.
شيء. احنا عندنا
او يقدر يدزه بالشات بوكس
10
خلال الزوم.
هسه 9:30 عندنا بالليل، يعني ما عندي شغل اقدر اجاوبكم. وبهم قولوا لي يعني استفدتوا من هاي النوع من المحاضرة؟ لو تريدوها انتراكتيف، سؤال وجواب، لو هيك احسن تسألون السؤال بالنهاية، كيفكم يعني؟
حاليا اكو سؤال من دكتور أمنية بالشات بوكس.
وين الشات بوكس؟ خليني ارجع chat box. How can we overcome the cultural boundaries of asking the sexual history as a student? أمنية أنت بياسر وينها موجودة أمنية؟
إيه موجودة.
مرحبا دكتور. أنا دكتورة أمنية، أنا خريجة العام من طب بغداد، وأنا يعني محاضرة في الكلية. Thank you so much for the presentation. I really enjoyed it. But the problem is, as students, and I'm reflecting on my experience, to be honest, the major boundaries of asking a complete OBGYN history is the sexual history. And for me, I would usually just skip it because I know I'm a female, but it is very difficult to go intimate to that degree, you know, and it gets super difficult for a male person to ask these questions to a female. And in our society, I've seen many females refusing to be examined or even taken history by a male. So what are the steps that we can, as a students, we can like train ourselves on? Because, you know, knowledge is important, skills are important, but attitudes are also important. And a major part of taking history is the good attitude of the doctor. So what about the OBGYN history, and especially the sexual history? Thank you so much.
Okay, so I would suggest if a student taking the history, the first thing is the teacher or the responsible person on that group comes and introduce and tell the patient, look, we are an academic institution and we are a teaching hospital. If we don't teach these students, we are the old people going to die. Who's going to treat you? Who's going to treat your daughter? Who's going to treat your granddaughter? And that's why I have a lot of Arabic patients here in Australia, and they do the same thing. And I have Lebanese patients, Iraqi patients, Turkish patients, Iranian patients. It's mixed multicultural in Sydney here. So when I have a student with me, it's easier with the female medical student, because female to female is fine. They are happy to talk or be examined in front of the student female. It's very challenging for male, I know, but if someone spend extra 5 or 10 minutes with the patient, so what I do in my clinic, if I have a student, I get the student to the next room. I'll get the patient in first. I say, look, حجية إذا عمرها بال50 بال60 أو إذا young, أقول لها, I have a medical student from this university. I am a teacher of these students. I'm a mentor. I have a responsibility towards these students to teach. And actually, if you let this student to listen to the history and be in the room with me, you are doing favor to us, me and the student. So you put the patient in the powerful, يعني تخليها هي موقع قوة. It's not بالأمر. You know, you are patient. I have to teach this to you. Like if you give them that power and feeling that, okay, if I let the student come and ask me questions and be in the room, then I'm actually doing favor to the society and to myself and to my mother and to my family, because when they learn, then they become beneficial member. Like إذا تشرحوا لهم هيك يمكن تاخذ 3-4 دقائق. If she said no, that's you can't force them. But I bet you, if you try spend extra 2-3 minutes with the patient before the student come in, and after then she relaxes, and if the يعني أعرف العدد والمشكلة بالعراق يجوز يعني المنتور الجروب هو كم واحد وشلون المسؤول يعني I can't imagine شلون احنا الستودنتس مالتنا مثلا ينطونا 4 students 5 بالهذا فيتوزعون ويا المقيمين الأقدمين ويا كأخصائي. ف we have a دبلوماسي يعني نستعمل الدبلوماسية والمريض قبل ما يكون موجود، نحسس المريض انه هم الكنترول بيدهم، السيطره بيدهم. اذا قالوا لا هم من يقولون لا بعدين ضميرهم يعذبهم من جوا، او فمن هذا اشوفهم دائما يوافقون. ما اعرف اذا قدرت اجاوبك على السؤال. يعني هذا الاستراتيجي مالتي، بس تنجح بالعراق ما تنجح بعد هاي different story يعني.
عاشت يديك عمي. أكو another question from منار خالد. منار حامد.
بالchat.
إيه دزيت هسه بالchat. Some people want like.
Some people want like the questions such as the sexual activity, partners. I mean, we are here in Iraq. It's kind of difficult to ask those questions. Can I avoid them? Of course you can avoid. يعني هو هاي مثلا أنا this is how we do it in Australia. And in Australia, people very open about the sexuality. In Iraq, So you need to modify your history taking. This is, I already talked to your Dr. Adnan Al-Amid and Mudhar, and I said, should I present Australian way or should I present Iraqi way? قالوا لا انت تسوي الأستراليان way and هم الستودنت أذكياء they can modify it يعني you need to open to see how we do things outside Iraq. Then you can modify your history. You can avoid it, but I think if you ask the patient, انت قصدك على multiple sexual partners or sexual partner, right? I don't understand. احكي إذا ممكن مرال.
منار حامد. You can unmute yourself.
Can you elaborate of your question? You mean like asking them about the sexual partner, or what do you mean? يعني for the rest of the students يعني انت تقدر تقول او انت تقدرين او انت يعني اذا انكم male or female تقول لها can I ask you a private question? This is part of my collision. When this is history, it's not me. This is how we need to ask. If you don't want me to ask, I'm going to skip this. But still mention, say, are you sexually active? Have you ever had sex? Because you want to know, is she going to have sexually transmitted infection or not? إذا واحدة تنكر هي sexually active وعندها gonorrhea وكلاميديا و HPV infection وما أعرف شنو الفائدة؟ ليش جاية على الدكتور؟ تقول عندي discharge but I'm not sexually active. You know, يعني هو defeats the whole purpose of the history and the examination. يعني تقولي لها مثلا I'm sorry, this is my calicia of question. تلزم الورقة بيدك هيجي تقول لها there is a question about whether you are sexually active or ever said. You don't have to answer me. It's totally you. If you say yes, I'll say yes. If you say no, I'll say no. Maybe they trust you and say, okay, I am sexually active. Can you please don't expose the file to anyone? Just keep it between doctor and patient relationship, because there's privacy. As a doctors, we have to protect patients' privacy. So they might confide to you. They might admit to you. يعني يقولوا لك أنا صح مش عندي مشكلة I'm sexually active بس ما حد ما يعرف for example بس أنت طبيبي أو أنت طبيبتي أنت تعرفين بساعديني يعني بس don't tell it and you واجبك كطبيب وواجبك كطبيبة إنه you never tell that to anyone. You keep it in the file and that file should never يعني إحنا عندنا privacy هنا ما حد ما يدخل الفايل مال المريض إلا الطبيب نفسه والممرضة. And even between طبيب and طبيبة ما نحكي على المريض because هذا top secret الprivacy مال البيشنت. فهذا one of the medical ethics يعني لازم ما نكشف سر المريضة. بس in reality يعني بالexam you can't avoid it. يعني even if the patient doesn't answer you, you should say, I tried to ask about sexual activity, but the patient declined. The patient refused. بس أنا إذا أنا أستاذ, I expect you to ask this question and demonstrate to me that you thought about it and you wanted to ask, but the patient declined to answer. So you need, if I'm an examiner, I will, if you skip it altogether because of cultural issues, you will not be forgiven. Dalal.
Yes. Thank you, Doctor, for a nice presentation. Doctor, some patients ask about diagnosis of their healthy. When I take history, in the end, they ask me how about my healthy. Can I answer of this question?
As a student?
Yes, fourth stage.
Are you talking about gynecology or general?
Yes, gynecology.
If you are a student, you say to them, I don't have the responsibility. I can't they give you a diagnosis. I am here, student, I'm learning, and thank you very much. You're giving me this opportunity to learn from you, but I am not allowed to tell you diagnosis or give you any information about your health. Because as a student, you should not give the patient diagnosis or prognosis or anything about their health. Legally, you should not.
Thank you.
And you can ask your superior, whoever is the registrar. احنا نسميهم registrar, انت هناك تسموهم permanent. Whoever is teaching you in that group, you can take that question to that doctor and tell them this patient is not clear about their health, and that doctor should go to the patient and tell them, what's your question? What is not clear in your mind about your health? Then legally, medical legally, it is the responsibility of the team doctor who's looking after her to answer that question.
There is a question from Dr. Muslim. Dr. Muslim, one of the staff in the Al-Ayen Medical College.
أهلا وسهلا. Can you, this one, can you please clarify
Yes.
to our student the alarming issues, dangerous signs and symptoms that may arise during history taking of a pregnant woman? دكتور مسلم موجود لو هذا بس ممكن تشرح لي السؤال شنو هو؟
مرحبا دكتور.
أهلا وسهلا.
مرحبا. Thank you very much for this presentation.
Have you listened to it?
Not all of it because it was sudden. We used to have it at night, but today
no problem.
اتفاجأنا إنه الساعة 2 فno problem إن شاء الله.
No problems. What was the question? Sorry, I didn't.
I am assistant prof Dr. Muslim. I am a family physician. ومن ضمن يعني السمر تريننج إنه ناخذهم إحنا برايمري كير we have vulnerable patients, pregnant ladies, and follow up and antenatal care. If you please can you clarify the issues in history, the alarming signs, alarming symptoms that may arise, like I say bleeding, like
for a pregnant lady.
For a pregnant lady specifically, because I plan to have a primary care setting here in the summer training.
This presentation was just for gynecology history because it was too long. I could not finish gynecology and obstetric in one day. There is another one. I send it to Mubarak as well. Maybe if we can set up another day for obstetric for pregnant lady.
No problem.
Yeah, because we just made today, so I don't want to confuse the students because we talked only gynecology today. We can do the obstetric presentation another day because it's only half an hour time. So I thought if I go too quick, then we lose. Yeah, no problems.
Any alarming sign even for gynecological history taking, like menopausal
I told them.
Symptoms of
So we've gone through, but I might summarize it. Like if someone come to you and say, if she's postmenopausal, she's having vaginal bleeding. Any postmenopausal bleeding, you need to think about cervical cancer, uterine cancer.
Exactly.
Postmenopausal bleeding. If someone comes with heavy symptoms in the, for example, weight loss, loss of appetite, abdominal swelling like ascites, you need to think about ovarian cancer, for example, or again, uterine cancer. All right, so this is like the cancers. Someone says, I can't pass urine. She's old, menopausal, have 5 babies in the past, for example. What might stop them bleeding? Sometimes they have vaginal prolapse, cystocele, rectocele, uterine prolapse is coming down. And in our societies, they usually ignore the examination of the female patient who's old. And the poor lady might have a big, large prolapse. In fact, I have a patient today. I took the prolapse photo in my phone for my patient today on the bed. I'll show you. You might be surprised. Can you see this? Can you see that large mass?
Yes.
This is prolapse grade 4. So she can't pass urine. The bladder is out of the vagina. All right. So this lady coming with acute urinary retention and no one bothered to look between her legs. She has complete vaginal prolapse. And the urethra is kinked and she can't pass urine. So we have to put a catheter for her and push it back in, and she's going to need urgent surgery. So like, this is a whole big subject here, you know, alarming signs. Can't pass urine, can't open bowel, vaginal bleeding in the postmenopausal bleeding ladies. Premenopausal, again, you need to divide it between age 18 to 45 or 50 premenopausal. Again, they can have vaginal bleeding, they can have infection like HPV infection or STDs, fever, bleeding, pain during sexual intercourse. All that can be alarming sign.
Thank you very much, Doctor.
No worries.
عاش ايدك عمي. حاليا انتهى الوقت. Time is over.
Thank you very much. Thank you. Enjoy your day. أهلا وسهلا. مع السلامة.
شكرا جزيلا.
Bye bye. Bye bye.